So today I did an evaluation on a patient who came in with Achilles pain. Starting off the evaluation, she tells me she's had problems with this before. It's been a reoccurring thing per track season she's had. She's a cross-country runner and a medium distance runner in track. So she comes in, obvious swelling on the Achilles, her left Achilles. Talks about having slight irritation of the Achilles around that area. So I begin my evaluation, asking questions. How long has it been going on? Track season only started on Monday, so the inflammation started between now and then. So at most 4 practices in, she's already had inflammation. So it's obviously not something that is directly related to practice. More so, something is wrong with either A, her flexibility, or B, another possible thing I can't think of right now, but that was my thought process as soon as I saw the patient. Pain pretty much localized to that area. I begin my assessment after I get a couple questions in. She also had a reoccurring hamstring issue that she hasn't had any problems with yet, so I mean, I'm not sure. I'm not ruling that out as not part of the problem, but it's definitely something I have to look into as I further review this patient. After getting most of my subjective, and I started my objective measures, going through range of motion. Passively, everything's good except for slight, she has less dorsiflexion in her left foot. There's about 15 degrees difference in the dorsiflexion of her left foot compared to her right, passively, and then actively it was even more of a deficit between the two. I believe it was about 20 degrees. No, not 20. It's about maybe 15, 17, somewhere around that area, deficit of her dorsiflexion. All the rest of her ranges of motion were within normal limits. It's just the dorsiflexion was slightly off. So I start to look at the Achilles area. I noticed that she has a lot of tightness in her left calf, which could possibly be leading to that. I performed a couple manual muscle tests. Strength-wise, her calf is strong, but like I said, there's just limited range of motion in that, and her ankle mobility as far as dorsiflexion. Special tests performed. I performed Thompson's test to assess Achilles attachment. Everything negative there. Assessed for deep vein thrombosis. I mean, it didn't show any signs of it, but just to check since I'm already in that area. Once again, came up negative. I also did an assessment of her gait. Gait seemed pretty normal. There didn't seem to be any abnormalities besides what I expect from calf soleus complex tightness, and the fact that she already had swelling in that area was, I mean, it's to be expected that her gait would be slightly off. So after all special tests, manual muscle tests, I kind of come to, I mean, it was a pretty obvious case, but I come to the conclusion she just has slight swelling in the Achilles tendon, gastroc soleus complex area. Swelling is only localized to that area, so we had her do an ice bucket to reduce. Well, we had her stretch first, so we had her stretch out her Achilles with a couple eccentric stretches, couple eccentric load stretches, so she raised up on 2 feet and then eccentrically contract on the way down on her left one to stretch that out all the way until she receives a stretch on it. Then we had her do a couple active stretches where she go up and stretch her Achilles on that foot and also kind of rotate to give it a little bit more stretch, multi-directional, playing more of a dynamic stretch and less of a static stretch. It's kind of something I picked up from Pete. He doesn't really like to have athletes do static stretching, more so have them do a dynamic version of it where they can hold that position, but they must also move in more than one plane of stretching to get the muscle to fire right, or to get the muscle more dynamically stretched, I guess. I'd say from this evaluation, one thing I do need to work on, or something I guess I should pick up on this semester, is learning like how to just kind of like different, coming up with different exercises and more functional ways to stretch muscles and come up with things. Like I had basic static stretches I could have came up with for the patient, and I mean they would have been effective, but not as effective as the thing that, I mean, Pete's been in practice for a while, so I can't blame him. But the learning how to do these, or learning different ways of doing things, like coming up with a dynamic-ish version of stretching versus static stretching to help the muscles loosen up more in a more realistic way, and less just stretching the muscle, more so getting the muscle prepared for any type of return to play activity, is just something I kind of want to make sure I focus on and realize that I need to work on that. In the end, I thought my diagnosis was pretty sound on the patient. She's going to come back tomorrow after practice, or come back actually tomorrow before practice to see if her swelling's gone down. We told her to go home, stretch some more, and then ice it right before she goes to sleep. So, and then even today, tomorrow in class, we told her to kind of like stretch it out at her desk, or kind of like put her foot at the, stretch it on the little carrying basket underneath the desk in front of her, and just try to get it loose as possible, and to see if we can get that Achilles or break up any adhesions that possibly are built up on the Achilles. Like I said before, the one thing I need to start to think about, or start to build it within myself and my skill repertoire, is understanding different functional stretches, different dynamic stretches to apply in my clinical practice versus just basics that I know right now. And that'll come with time, I know, but it's just something that I wouldn't even thought about if Pete hadn't showed me it. And this has been my review of my lower body injury.